Hello, everybody, and welcome to this presentation on thyroid-adrenal connection. Just want to make sure I can see my sound okay. So thank you for joining today. This is really an intriguing topic. So what I promised you was this webinar on the thyro-adrenal connection, sort of when the patient's metabolism shows signs of low thyroid, but the blood tests are normal. So let's look at this outline that I provided originally. What I said was that most practitioners, and I'm sure you've seen this, often see a middle-aged patient, usually a woman, not always, who shows signs of an underactive thyroid based on the symptoms of either fatigue or difficulty in losing weight, easy weight gain, cold hands and feet, skin texture changes, lowered resistance to infection, changes to their hair. But upon medical testing or lab testing, the person's thyroid function tests appear to be in what is in the medically accepted range. However, more and more experts in this area are recognizing that the conventional way that endocrinologists and family doctors look at those blood tests may underdiagnose a subclinical hypothyroid situation, or what we call thyroid dysfunction, where you could step in and actually be a tremendous asset to the patient. So many middle-aged adults are actually walking around suffering from symptoms of suboptimal thyroid function or thyroid dysfunction, not really being managed optimally, let's put it that way. So I'm going to sort of review the physiology behind this and show you how to provide patients with sort of nutritional medicine strategies where it can be helpful to help improve thyroid function, and sometimes in combination with addressing adrenal support as well, as you will see. So these are sort of the key takeaway points, almost like the summary of the program, if you will, that I'm putting up front. You know that thyroid hormone, both T4 and T3, set the body's metabolic rate. That's not a surprise to anybody. So in hyperthyroidism, right, when there's too much thyroid hormone, it speeds metabolism up. And in hypothyroidism, of course, the person's metabolism slows down. So low blood levels of T4 and T3 normally trigger the hypothalamus to release thyroid-releasing hormone, which in turn prompts the pituitary gland to secrete thyroid-stimulating hormone. And then that TSH travels to the thyroid gland and stimulates the synthesis and the release of the two thyroid hormones, T4 and T3. T3 is actually the most potent form of thyroid hormone, helping to maintain metabolism. So the peripheral tissues of the body convert a significant amount of T4 into T3 to optimize thyroid hormone function on peripheral tissues. Sometimes that doesn't happen really efficiently. What we see is, you're going to see in the research here, is that the herb known as gum google can help to facilitate increased conversion of T4 and T3 and effectively improve thyroid hormone function on peripheral tissues, speeding up metabolism and doing some other things that are quite desirable. So a high TSH, a high thyroid stimulating hormone blood level, is not hyperthyroidism. It implies an underactive thyroid. If the pituitary gland is having to secrete higher amounts of TSH, it means the thyroid gland is not responding that well. So a high TSH blood level indicates that the thyroid gland is not responding and you have an underactive thyroid. In certain cases where it's just a thyroid dysfunction problem and not overt hypothyroidism, the herb Coleus forskolin can actually help stimulate the thyroid to secrete and release more thyroid hormone, T4 and T3. So this can be very helpful in thyroid dysfunction problems. If these support nutrients are helping, then a few months later, when the person's TSH blood level is tested again, the TSH should be lower. So it means that now you need less TSH to stimulate the thyroid to secrete those hormones. Whereas a low TSH level under 1 micromole per liter suggests hyperthyroidism. So a very low TSH suggests that the thyroid gland is overactive, secreting high amounts of thyroid hormone, and therefore it doesn't need to be stimulated with as much TSH. So that happens in an autoimmune condition called Graves' disease, which is a condition where we're going to look at it, where you have these antibodies that are sort of attacking the thyroid and causing a greater amount of thyroid hormone release. And so you get all the signs of hyperthyroidism. Remember that to synthesize thyroid hormone, the thyroid gland must have ample amounts of iodine, because that's the prosthetic group, and also the amino acid tyrosine. So what we've learned so far is that there's 4 different nutrients that can be helpful to the thyroid gland under certain conditions. They would be iodine, tyrosine, gum-gugel, and cholecystokinin. We're going to come back and revisit that. A lot of people don't get the RDA levels or the desired amounts of iodine from day to day. And this starts to play a role in not only thyroid function, but also risk for women of having children to have developmentally challenged children mentally, as you're going to see. Also, the role of chronic stress, where cortisol levels are sustained at a higher level. That higher cortisol has been shown to block the effects of thyroid hormone at peripheral tissues and can also produce insulin resistance. Both of these outcomes are going to increase the conversion of carbohydrate into fat, increasing weight gain and possibly slowing down metabolism. Thus TSH and the free T3 and free T4 blood levels can be in the ideal range, but the effect of T3 and T4 is blunted at the peripheral tissue level by cortisol. So you can have normal thyroid blood tests, is what I'm saying. But when thyroid hormone, either T3 or T4, tends to try to stimulate metabolism at the peripheral level, the effects are inhibited by the high cortisol levels. So it's almost like having a hypothyroid condition, even though thyroid tests are normal. Slowing down metabolism. The other thing that cortisol tends to do is it inhibits the conversion of T4 into T3. And when that happens, metabolism slows down, and it also leads to insulin resistance because you need T3 to activate the GLUT4 receptors so that blood glucose can get into the cell. So you end up with higher insulin levels and sort of glucose regulation that is not ideal. And you're converting more carbohydrates into fat when insulin levels are high, resulting in weight gain. At the same time, really sudden acute stress tends to increase both cortisol and thyroid hormone levels. And often you've seen this in patients where they all of a sudden they go into acute stress. You know, a spouse dies, a divorce comes out of nowhere, the person loses their job. And what you see is actually hyperthyroidism and high cortisol levels causing lean mass catabolism, and metabolism speeds up. They're losing weight. And it can also trigger, if they're genetically susceptible, it can trigger the onset of Graves' disease, this autoimmune condition, and or what we call thyroid storm. So acute stress can cause hyperthyroidism. Chronic stress tends to increase the likelihood of hypothyroidism symptomatology, even though thyroid tests are normal, because you have cortisol blocking the effects of thyroid hormone, and or you have a decrease of conversion of T4 into T3, and you have then glucose intolerance developing as a result of that. So here's this high-level view that you're familiar with. I just like to revisit things from time to time. So the hypothalamus, sort of controlling a lot of these hormones, releases thyroid releasing hormone, corticotropic releasing hormone, and gonadotropic releasing hormone to the pituitary gland. And they the pituitary gland responds respectively by secreting TSH, which stimulates the thyroid gland to secrete T4 and T3. From corticotropic releasing hormone, it will in turn secrete ACTH to the adrenal cortex to secrete cortisol. And the gonadotrophin hormone, of course, stimulating the release of luteinizing hormone and follicle stimulating hormone. But remember that stress can override all of this and create sort of endocrine dysfunction throughout the body, not only of thyroid hormone and not only of cortisol, but even some of the other hormones like estrogen and progesterone, as you're going to see, and cause dysregulation of menstrual cycles. So with respect to thyroid function, you see that here's the thyroid releasing hormone to the pituitary, then the TSH to the thyroid gland. The thyroid gland synthesizes and releases T4 and T3, but then there's a peripheral conversion of T4 to T3. And that's a very important conversion because T3 is the most active form of thyroid hormone. When these levels are elevated, it sort of shuts this system down so you don't oversecrete these hormones, both at the primary level, hypothalamus, and also the secondary level at the pituitary gland. And when TSH stimulates the thyroid gland, it increases its synthesis of thyroid hormone by using iodine and the amino acid tyrosine to start making thyroxine, which is T4. That's 90% of what gets secreted. And then you have T3, which is triiodothyronine. But this has the greatest metabolic activity. Remember, a lot of T4 at the peripheral level gets converted to T3. And with respect to tyrosine, tyrosine is an amino acid found in food. The body can convert some phenylalanine into tyrosine, but in people that have phenylketonuria, where they have a genetic impairment of making that conversion, then they have to stay away from phenylalanine containing foods and beverages. That's why they can't have aspartame, because it contains phenylalanine, which can cause very, very serious neurological damage. Tyrosine has its own metabolism, as you see, but tyrosine is also the building block from which the thyroid gland makes thyroxine, or T4, and also T3. And this is a little bit of a misrepresentation, this arrow here. Tyrosine in one pathway becomes melanin. So people that have albinism, or they become albinos, are missing that enzyme that converts tyrosine into melanin, so they can't make melanin pigment in their skin and in the iris of the eye, and in their hair as well. And tyrosine also becomes dopa. From dopa, you make dopamine, norepinephrine, and epinephrine, these neurotransmitters. So tyrosine is a very pivotal amino acid for a lot of reasons, but one of its functions is that it makes T4 and T3 thyroid hormone. So here you see the T4 thyroxine hormone made by the thyroid gland. Notice so that's the tyrosine ring. There are two of them. And it's called T4 because at 4 prosthetic sites, you have iodine that acts as the prosthetic group. And then when T4 becomes T3, one of the iodines is removed. So T3 is basically just T4 with one less iodine. That's why it's called triiodothyronine. But this is the more potent form of thyroxine, is T3. So now we're going to talk about hypoclinical, sort of low-grade hypothyroidism, or subclinical hypothyroidism, or thyroid dysfunction. But let's get a bigger picture of thyroid. Let's just touch on hyperthyroidism for a moment. This is when you have an excess synthesis of thyroid hormone from being secreted, and it's going to upregulate metabolism. The most common forms of hypothyroidism include diffuse toxic goiter, or Graves' disease, which is an autoimmune disease that we'll look at. Also toxic multinodular goiter and toxic adenoma. In thyrotoxicosis, this is usually caused when a person already has hypothyroidism and they give them drugs for thyroid hormone replacement drugs to speed up their metabolism and to substitute for the hormone they're not making themselves normally. But if they get the dose wrong and they give them too much, it leads to thyrotoxicosis. It's usually caused by over medication until they get the medication adjusted correctly. In Graves' disease, or in any form of hyperthyroidism, remember that exophthalmos is a very common early finding that you should be on the lookout for, because Graves' disease is actually very common. Treatment of hyperthyroidism includes symptom relief as well as anti-thyroid pharmacotherapy like radioactive iodine therapy, and also radiation treatment in some cases. So they take someone who has hyperthyroidism and they want to sort of tone down the activity of the thyroid gland. So you can radiate it to do that. You can give radioactive iodine. The radioactive iodine goes into the thyroid gland and destroys the tissue. Or in some cases, you can actually do surgical removal of it. And people that have thyroid cancer, they often will use some combination of these things, usually surgery, and then followed up with radioactive iodine and or radiation. The thing about thyroid cancer is that it's not the treatment is 99% effective. And usually you can catch it early because the person will show up with sort of a lump in their throat. And then upon biopsy, they see cancer and they remove it. And then they apply some of these secondary measures. You have a 99% success rate. So any patient that has an abnormal lump in their throat, make sure they go and get that assessed, including a biopsy if necessary. For hypothyroidism, this is when you have insufficient production of thyroid hormone. So the same way that Graves' disease can cause hyperthyroidism, it's an autoimmune disease. Another autoimmune disease, Hashimoto's thyroiditis, causes an underactive thyroid, because Hashimoto's thyroiditis is actually causing destruction of the thyroid gland, whereas Graves' disease is causing an irritation to the thyroid gland, producing lots of thyroid hormone. But Hashimoto's is the opposite. It's actually slowly destroying the thyroid cells. Also you get hypothyroidism. If you treat somebody who has hyperthyroidism, you treat them with radioactive iodine therapy, or you remove their thyroid gland, now they're going to have a hypothyroid condition. You're going to have to give them medical treatment to give them enough thyroid hormone. Historically, iodine deficiency used to be the most common cause worldwide of hypothyroidism. But now that we have iodized salt available, that has corrected these problems in much of the modern world, at least. You can have secondary hypothyroidism if the pituitary gland is not able to secrete TSH because it's damaged by a tumor or radiation or surgery. And you can have tertiary hypothyroidism if the hypothalamus doesn't secrete thyroid releasing hormone to the pituitary gland, again, through tumors, radiation, surgery. So if we look at Hashimoto's thyroiditis, it's also known as chronic lymphocytic thyroiditis, the most common cause of overt hypothyroidism in the United States. It's an autoimmune disorder. It often runs in families. Over time, the ability of the thyroid gland to produce thyroid hormone often becomes impaired, and the thyroid gland becomes extremely underactive, and the person needs thyroid hormone support. It's most commonly found in middle-aged women, but can also affect men and children. But you often be on the lookout for a middle-aged woman who's starting to show signs of an underactive thyroid. And this is a slide that summarizes a lot of those things. In Hashimoto's thyroiditis, the thyroid gland is starting to enlarge, and you're getting signs of slower metabolism associated with that. And often joint pain, cloudy thinking, other changes that are consistent with sort of an underactive thyroid. So blood tests are done, right? So when you see high levels of TSH, it indicates that thyroid is not responding well to the signals from the pituitary gland. And as TSH rises higher, eventually the diagnosis is made of hypothyroidism. But doctors should also be looking at the T3 and T4 blood levels as well, the actual thyroid hormone itself. In routine analysis, if you go for just an annual physical exam, you don't have any symptoms of an overactive or underactive thyroid, normally they just will do a TSH blood test. But I'll show you that the value of the TSH blood test is actually invaluable if you get to see the numbers. The person has hypothyroidism that is, really overt. They're going to be treated with synthetic thyroid hormone that they call Synthroid or levothyroxine, one of these synthetic drugs. The synthetic drugs are basically a form of T4 or thyroxine. It is not T3. The clinical applications for thyroid hormone replacement then is over hypothyroidism in situations where there's goiter. The common side effects of thyroid hormone replacement, because it's such a tricky drug for doctors to work with, because it's in microgram doses. They have to get it exactly right. So in the early stages of treating a patient, often they're sort of through trial and error trying to find the right dose. And often they give the person a little bit too much, which can lead to palpitations, nervousness, headaches, insomnia, swelling, increased weight loss, increased appetite. So they have to try to get that dose down so the person feels normal. And it's a bit of trial and error. So again, I just want to note that in hyperthyroidism, often caused by Graves' disease, the patient may be treated with radioactive iodine, drugs, radiation, or surgical removal of the thyroid. In Graves' disease, the autoantibodies chronically stimulate thyroid receptors, prompting them to continually produce thyroxine hormone. I spelled thyroxine hormone wrong. The opposite effect occurs in Hashimoto's thyroiditis, where you get hypothyroidism. So how do you assess the thyroid gland? Well, this is where this becomes clinically relevant to you today. That is that the medically accepted range for TSH blood levels, thyroid stimulating hormone blood levels, is between 0.2 and 5.5 micromoles per liter. So that's a big range. If the TSH level is over 5.5, then the person's considered to have overt hypothyroidism. If the level is under 0.2 micromoles per liter, they're saying that the person has hyperthyroidism. But a lot of the more progressive medical doctors today are saying that range is too wide. As soon as the ideal range for the TSH is actually between 1 and 2. As soon as the person's between 2 and 4, they already have thyroid dysfunction. They might already have easy weight gain, trouble losing weight, slower metabolism, but doctors aren't going to diagnose it as hypothyroidism and start treating it accordingly. They're just going to say, no, your thyroid level's normal. As soon as the TSH level is above 4, often that increases the risk of heart disease. So that's a serious situation. In terms of hyperthyroidism, as soon as the TSH level is below 1, they already likely have a very overactive thyroid gland. So what I'm saying is that you can't just say that when the patient says, I had my blood work done, my doctor said that my thyroid function is normal. You can't just accept that at face value. You have to say, what is your TSH blood level? As soon as it's out of the range of between 1 and 2, that is not normal. As soon as it's under 1, there's hyperthyroidism going on. As soon as it's over 2, the metabolism is slowing down. Between 2 and 4, there are certain things you can do to really help. Once it's over 4, the person should be arguing for thyroid hormone replacement to decrease the risk of heart disease, actually. So what do you look for clinically in thyroid dysfunction or subclinical hypothyroidism? That means a TSH level that's between 2 and 4. So a TSH level above 4 strongly increases risk of heart disease and symptoms of underactive thyroid. So between, let's say, 4 and 5.5, doctors still are reluctant to give thyroid hormone replacement. And the person often is going to show up with physical and mental depression. Often, these are patients who take antidepressant drugs, but they don't respond because their thyroid function is compromised. They have lower resistance to infection. They don't recover very quickly. They have difficulty losing weight. They gain weight easily. They're tired. They feel cold often. They have cloudy thinking. Their skin becomes drier and more flaky. They may have constipation, prolonged menstrual bleeding that doesn't improve when they're given estrogen and progesterone hormones. When you see this pattern, you start thinking this could be subclinical thyroid dysfunction or thyroid dysfunction, where the TSH blood level is anywhere from 2 to 5.5, where doctors are reluctant to make a diagnosis of underactive thyroid. When the TSH level is between 2 and 4, then you might get some mix of these symptoms. And this is where certain supplements can be highly advantageous in many situations. So once again, to review, the ideal TSH level that's emerging now is between 1 and 2 micromoles per liter. So look at the patient's blood work and actually see the numbers, because physicians consider anything under 5.5 to be normal thyroid function, but it really isn't. For instance, I had my own blood work done. My TSH level is 2.2, right? So it's out of the range of between 1 and 2. As people get older, often it starts to creep up a little bit. A TSH between 2 and 4 indicates thyroid dysfunction. That's very common in people, starting at age 40 to 50. And it often responds by giving them thyroid support nutrients. So you start giving people a combination of tyrosine, iodine, coleus, forskolin, and gum google. And then a number of months later, when the TSH level is retested, the TSH level is now lower because the thyroid is now responding more effectively to stimulation. So you need less TSH, and you see you have more normal thyroid function. Once the TSH blood level is above 4, the best thinking on this subject is that the person would actually start benefiting right there and then from thyroid hormone replacement treatment that is prescription based. But even in those cases, giving people thyroid support nutrients to enhance the efficacy of thyroid hormone replacement drugs is highly beneficial for a lot of people. The thing is, there are a lot of these thyroid dysfunction cases that are out there where you can be very helpful. So treating thyroid dysfunction and hypothyroidism. So thyroid dysfunction between 2 and 4 micromoles per liter. Thyroid and adrenal support supplements are often helpful in these cases. The thyroid support nutrients of L-tyrosine, iodine, coleus, forskolin, and gum google can help to increase thyroid hormone synthesis and release and increase the conversion of T4 to T3. I'm going to show you the research on that. At the same time, adrenal adaptogen supplements can help reverse high cortisol level, which typically interferes with thyroid gland function and thyroid hormone function at the gene receptor level within the cells of the body. So sometimes, as I said earlier, high cortisol can block the effects of thyroid hormone on peripheral tissue. Giving the person adrenal adaptogen herbs like rhodiola, schisandra, ashwagandha, like Adeeva's adrenal support formula, bringing the cortisol levels down, helps the thyroid hormone have its effects on the peripheral tissue. If the person needs thyroid hormone replacement therapy, one of their options is that they get a prescription for desiccated thyroid, which is prescription only in Canada. It provides both T4 and T3. So a lot of the more functional medicine medical doctors prefer giving desiccated thyroid to the synthetic Synthroid and levothyroxine because it's only a T4 product, whereas desiccated thyroid is both T4 and T3. Once the person's TSH level is above 4 micromoles per liter, some form of a prescription thyroid hormone is likely going to be helpful for them. If patients require thyroid replacement, whether it's synthetic or desiccated thyroid, it often helps to provide them with thyroid support supplements. And if stress is high, often adrenal support supplements can also help to make those medications work better as supporting actors on the scene. So there's this company called Armour Thyroid. They make these desiccated thyroid tablets. So the way that the functional medicine doctors convert the synthetic thyroid to the dose of desiccated thyroid is using this reference table. And in Canada, I don't think Armour Thyroid for a while was not allowed here. Not sure if it is now. A lot of Canadian doctors go to this website to get ERFA tablets that comes in different dosages. So I sometimes will refer a patient like that to one of the integrative medical doctors that I know who sort of see eye to eye on this and will use desiccated thyroid hormone replacement for patients who have a TSH that's above 4 micromoles per liter. Sometimes it works better, but I also give them Thyro-Support supplements to also enhance the efficacy of the thyroid hormone that they're on. So in terms of free T4 and free T3, you see the medical reference range is very wide, whereas what functional medical doctors now consider to be the ideal range is much more narrow. Same with T3 down here. Here's the medical reference range, but it's a tighter ideal range to really understand the efficacy of thyroid hormone replacement on peripheral tissues. So some individuals have a difficult time converting T4 to T3. In these cases, supplementation with thyroid support nutrients can be beneficial. But remember that the Armour desiccated thyroid is both T4 and T3, whereas synthetic thyroid is only T4. If the free T3 levels are below 2.6 or the T4 level is below 0.7 nanograms per deciliter, then thyroid hormone replacement is also likely required. So it helps to also know the T4 and T3 when you start looking at people that have more severe symptoms. So this is an example of a Thyro-Support formula. This is the one that I created for Adeeva Nutritionals, called Thyro-Support formula. It's a great intervention for those that have a TSH blood level between 2 and 4, where they have thyroid dysfunction, the subclinical hypothyroidism, that's not life-threatening to heart disease, where they're just in that early stage of hypothyroidism. It's very helpful. It's a lot of patients that you're seeing right now, shockingly, because remember that doctors don't consider you to have hypothyroidism until you get to 5.5 micromoles per liter. This product can also be used as an adjunct in those taking thyroid hormone replacement prescription medications, but it doesn't replace the need for thyroid hormone replacement. You can't take a person off thyroid hormone replacement and put them on this supplement. That's asking for all kinds of serious consequences. So you cannot do that, but you can give it to help improve the efficacy of what those drugs are doing. So the ingredients, again, are coleus forskolin at a standardized grade, iodine, tyrosine, and gum-gugal at a standardized grade. Now, I've taught you about gum-gugal before when we looked at the fact that gum-gugal also helps to lower cholesterol, which for someone who's a little bit hypothyroid, lowering their cholesterol further, as well as converting more T4 to T3, is actually extremely beneficial to improve thyroid function, which also helps to reduce cardiovascular disease, as does lowering their cholesterol levels. So you sort of get a double benefit from the gum-gugal in this situation. So the functions of those 4 ingredients, again, tyrosine is the main amino acid required as the building block for thyroid hormone. Iodine is the prosthetic group of thyroid hormone. Coleus forskolin helps to convert T3 to T4, as I'll show you in the research. And coleus forskolin helps to stimulate a greater release of T3 and T4 in some subclinical hypothyroid cases. And gum-gugal helps the conversion, as I said earlier, of T4 into T3. So let's look at some of the research on this, gum-gugal and thyroid, the update in 2019. The researchers have shown that gum-gugal helps the body get more access to T3. It supports the healthy conversion of thyroid hormone in the body. Back in 1984, this was first recognized. Further researchers has confirmed and clarified these findings that gum-gugal extract increases the conversion of T4 into T3, which is the most active form of thyroid hormone. And you want your patients to have, if they're showing signs of underactive thyroid function, to be able to convert more T4 into T3. Again, it also helps to lower lipids like cholesterol and triglycerides. This is an important benefit as hypothyroidism, even subclinical hypothyroidism, and elevated cholesterol may occur, concurrently. That's not uncommon to see slightly low active thyroid function and a rising cholesterol level and triglycerides. Here are more references on gum-gugal with respect to that. References on Adeeva Thyro-Support formula right across the board. You can come back and revisit those references as you like. But in terms of Thyro-Support formula, there's certain people who you can't give it to. Someone who's undergoing radioactive iodine treatment for cancer or for any type of thyroid disorder, if they're on radioactive iodine treatment, or they're undergoing radiation therapy of the thyroid gland, or they've had thyroid cancer and they're being treated with radioactive iodine or follow-up radiation, you can't give them Thyro-Support formula because it contains iodine, which will compete and try to override the radioactive iodine. So you're countering the medical treatment. Same if you give them kelp or any iodine containing supplement is going to interfere with the thyroid treatment that they're undergoing. So you don't give people Thyro-Support formula or any iodine containing supplement if they're undergoing radioactive iodine treatment. I'm saying that because a naturopath got sued for doing that very thing and was found guilty. and negligent for giving the person an inappropriate supplement during the course of medical treatment. What about the adrenal-thyroid connection and thyroid dysfunction and subclinical hypothyroidism? So in 2012, recent attention has been given to subclinical hypothyroidism, defined as an elevation of TSH. They're saying here between 4.5 and 10 micromoles per liter, with T4 and T3 in the normal range. But they're saying controversy exists. So if you jump down to the conclusion here, they're saying, you know what? Results now suggest a positive relationship between TSH and cortisol in apparently healthy young individuals. And as much as this relationship may herald a pathologic disorder, these preliminary results suggest that a TSH level above 2 micromoles per liter is abnormal. And it is abnormal. That's when you start to see a slight slowing of metabolism that can become very frustrating for people as they get older, as they eat less and exercise more, and they can't lose weight and they keep gaining weight, even though they've been diagnosed as not having a thyroid problem. As soon as the TSH is above 2, there's already some hypothyroidism going on. You can be helpful by giving them, at the very least, thyroid support nutrients. What about the impact of cortisol? Well, here's some of the evidence here that I referred to earlier. Too much cortisol secreted by the adrenal glands in response to stress causes tissues to no longer respond to thyroid hormone, creating thyroid resistance, meaning the thyroid hormone levels can be normal, but tissues fail to respond. So where you have normal thyroid blood tests and the person still has this increased weight gain, you start thinking maybe stress is a factor. This is where adrenal support nutrients, sort of meditation, biofeedback, all these things can also be helpful. You want to get that cortisol levels down. And that high stress response also can disrupt other hormones, as I talked about earlier: insulin, progesterone, estrogen, testosterone, and again, cortisol as well, creating sort of generalized endocrine dysfunction, sort of giving this sort of multimodal series of symptoms where just getting the cortisol level down is helpful. This is where Adëeva adrenal support can often be very useful. The symptoms of thyroid deficiency are often expected to occur when thyroid therapy isn't working. So if the person's given Thyro-Support nutrients and it doesn't help, you might want to consider giving them also adrenal support. Or if they're already on thyroid hormone replacement and it's not really giving the effect that the doctor was anticipating, it might be that cortisol levels are high. So, say as you go down to the bottom paragraph here, say the person doesn't have abnormal thyroid blood tests and yet they have symptoms of thyroid deficiency, you may want to look at the adrenal glands first before starting treatment with thyroid hormones. So if the TSH is in the normal range and the person is having this sort of unusual weight gain, you might want to think, if it's because of stress, maybe I use adrenal support nutrients before I start using Thyro-Support nutrients. That's what I'm trying to get at here. In 2011, we saw this research in the Indian Journal of Endocrinology and Metabolism saying this: in the modern environment, one is exposed to very stressful conditions. Stress can lead to changes in the serum levels of many hormones, including glucocorticoids, catecholamines, like dopamine, norepinephrine, epinephrine, growth hormone, and prolactin. Some of these changes are necessary to further fight or flight response. Some of these stressful responses can lead to endocrine disorders like Graves' disease, gonadal dysfunction, psychosexual dwarfism, and also obesity. So stress can impact all of these different things. So how does cortisol inhibit the active thyroid hormone and suppress immune system? Well, this was published in 2018. Studies show that cortisol, your body's stress hormone, increases thyroid stimulating hormone, as well as inhibiting the conversion of T4 to T3, which is your body's metabolically active thyroid hormone. This process mostly occurs peripherally in the liver, GI, skeletal muscle, but also occurs in the thyroid and also in the brain itself. And in 2021, they did a study of 54 undergraduate students published in the European Journal of Inflammation. And they said thyroid hormone activities can be altered by cortisol levels. So in this study where there's acute stress, it's like going into exams, the study showed that there's a significant difference in the release of TSH and T4 with the highest values in high-grade students and the least values in low-grade students. In other words, during exam stress, it's almost helpful for TSH levels and T4 levels to rise to improve cognitive function for over the short term to actually improve test scores, which is very interesting. Previous studies show that increased secretion of thyroid hormone levels in serum had been observed in stressed animals, in acute psychiatric patients on admission, as well as in medical students during examinations. So during these periods of heightened stress where TSH levels are really high, oftentimes you get this cognitive response where the person's on all alert. It can also trigger possibly some psychiatric problems or occur concurrently. Some animal studies show that if you combine that with a high-fat diet, it starts to decrease the T3 levels. We don't know how that applies to humans yet. What about why can insulin resistance be a normal consequence of thyroid dysfunction? Well, T3 is required for optimal glycogenolysis to break down glycogen and also for the GLUT4 insulin sensitivity. So for insulin to work on fat cells and muscle cells, it has to open up the GLUT4 receptor, and that gets T3 is required to make that all work normally. So increased cortisol levels due to high stress can inhibit the conversion of T4 to T3, which is important for glucose control as it affects the number of insulin receptors available and how the receptors actually respond to insulin. With regards to subclinical hypothyroidism, insulin resistance has been demonstrated in some but not all studies. However, in some of these negative studies, hyperinsulinemia was reported in subclinical hypothyroid subjects and interpreted as an early sign of impaired glucose metabolism. So it seems to be that when you start to get into low-grade thyroid dysfunction or subclinical hypothyroidism, a TSH between 2 and 5.5, that you're also going to impair normal glucose metabolism and have some hyperinsulinemia, which converts more carbohydrates into fat and helps to increase weight gain and give you some decreased glucose regulation. In hypothyroidism, the results are less evident. However, the available data suggests that insulin resistance is present mainly in the peripheral tissues when you see these sort of hypothyroid conditions. That explains the reasons why. So the result is this. With insulin resistance, the liver converts more carbs into fat due to high circulating insulin, which increases fat storage and a gain in body fat, and less T3 also slows down overall metabolism. So as you get into this hypothyroidism state with less T3, you're slowing down metabolism and also impairing normal glucose function and leading to more hyperinsulinemia, converting more carbs into fat. This is just a summary image here of all of this. So if you click on the link that you see in blue, it'll give you sort of the complete picture of how thyroid hormones are impacting glucose metabolism throughout the body. Cortisol and stress. Activation of the pituitary-adrenal axis as a prominent neuroendocrine response to stress, promoting survival. Stimulation of the axis results in hypothalamic secretion of corticotrophin releasing factor. So with stress, you release more CRF. The CRF then stimulates the pituitary gland to secrete more ACTH and other things that are then going to release a greater amount of cortisol, obviously. But that same part of the hypothalamus deals with the stress response is also going to modulate the secretion of norepinephrine and serotonin and acetylcholine. And it's going to play into the entire stress response that affects the nervous system as well as the neuroendocrine system. The relationship of stress, hyperthyroidism, and Graves' disease is very interesting. The relationship between acute stressful events and the onset of Graves' disease was first documented back in 1825. There's data available on the high incidence of thyrotoxicosis among refugees from Nazi prison camps. Acute stress tends to trigger hyperthyroidism. Psychological distress has been reported up to 65% of younger patients with hyperthyroidism and physical stress in many older patients. So as soon as stress is very acute, if the person is genetically susceptible, it'll often trigger Graves' disease, of course, which is hyperthyroidism. So they think that a defect in the antigen-specific suppressor of T lymphocytes has been proposed to partially be responsible for the initiation of Graves' disease. Stress may result in a defect in the immunological surveillance, leading to production of TSH receptor antibodies, so destroying those receptors in the thyroid gland. In genetically susceptible individuals, stress favors the development of Graves' disease by shifting the T1, T2 immune balance away from T1 and towards the more inflammatory autoimmune associated Th2 profile in the T lymphocytes known as the CD4 cells or the T helper cells. As soon as they shift to T2, that tends to imply an autoimmune disease is likely to occur. And this shifting occurs as a response to stress in people who are genetically susceptible. So thus stress combined with genetic predisposition is likely part of the formula that triggers Graves' disease in some people. As I said earlier, the treatment is radioactive iodine and irradiation to the thyroid gland. So I knew a person, still know them, who developed Graves' disease, and they wanted to treat her with radioactive iodine. And she said, I don't want that treatment. I said, well, Graves' disease is very dangerous. If your thyroid hormone goes too high, you'll have palpitations and a heart attack, you'll die. She said, you have a thyroid condition. She said, I don't have a thyroid condition. I have an immune system condition. It's my immune system is attacking my thyroid gland. My thyroid gland is the victim. It's not the problem. But if I can regulate my immune system so it doesn't attack my thyroid gland, then what do I need your treatment for? They said, well, it's not possible to do that. So I wouldn't say that in every case it's possible to do that, but in her case, she was able to control and get all her thyroid hormone tests into the normal range by using supplements that modulated her immune system. She used adaptogen herbs and immune modulators like medicinal mushrooms and astragalus and ashwagandha and schisandra and rhodiola. And she ate foods that were goitrogen containing foods like a lot of cruciferous vegetables and soy. And she was able to actually control her Graves' disease, and she still does to this day without medical treatment. I'm not recommending that as a therapy. I'm just saying that her take on it sort of got my head spinning, because when you study this in school, in any school where you become a health practitioner, Graves' disease is a thyroid condition. But she's actually right. It's actually an immune system that's gone out of balance, and the thyroid gland is the victim. So she was able to control it this way. I'm not saying that's the right approach, because Graves' disease can be very dangerous if it's not managed properly. She was able to manage her condition this way. What about the iodine story? Well, the iodine story is much bigger than just the fact that the thyroid gland needs iodine. Here's what we've seen in recent years. We're starting to wind down now. Many young women are now adopting dietary practices of avoiding consumption of all dairy and animal products, including fish, and using sea salt and other salt substitutes in place of common table salt. So they're avoiding iodized salt because they want to have all things natural. One of the unintended consequences is that an increasing number of young women are now find themselves at increased risk for having children born with impaired neurological conditions due to poor iodine intake. A small study in South Australia recently showed this finding, but in 2017, a US study found that nearly 2 billion people worldwide were iodine deficient, resulting in 50 million experiencing clinical symptoms of iodine deficiency. Of importance to young women is the fact that just mild to moderate iodine deficiency has been shown to affect language development, memory, and mental processing speeds in their offspring. In fact, the need for increased iodine intake occurs during pregnancy, but studies show that most women don't ingest the amount of iodine that's desirable even before pregnancy occurs, nor do they consume the increased amount required during pregnancy and lactation, which goes up to 220 and 290 micrograms per day, respectively. As was stated at the 1990 World Summit for Children, iodine deficiency remains the single greatest cause of preventable brain damage and mental retardation worldwide. Eliminating iodine deficiency was recognized as one of the most achievable of all the goals set in 1990 at the Children's Conference. They thought they could do it by the year 2000. Unfortunately, the year 2000 has come and gone. When many women who live in modern countries who have ample access to foods that are rich or fortified with iodine are now avoiding them. So dietary strategies such as plant-based beverages, oat milk, soy milk, etc., in place of dairy products, avoiding all dairy products, avoiding all meaty foods, including fish, and using Himalayan sea salt and other salt alternatives that are not fortified with iodine, as well as avoiding bread products, have led to an increased number of young women becoming mild to moderately iodine deficient, which does not present with any physical symptoms, but lays the foundation for brain development problems in their children should these women become pregnant. This is important. A more plant-based diet is desirable, no question, for many reasons, including reducing risk of cardiovascular disease and many types of cancer. It's also better for the environment and the ecosystem, not to mention the animals themselves. But it has to be done intelligently, not guided by just philosophical principles, all things natural. An iodine food fortification program exists in many developed countries for a reason, which is to help avoid the consequences of widespread iodine deficiency and insufficiency, which commonly occurs in populations where iodine-rich and iodine-fortified foods are not even available. The daily requirement for iodine for most adults is 150 micrograms per day. As little as a quarter teaspoon of iodized salt contains 76 micrograms. As well, many flours and bread doughs are enriched with iodine, often producing about 180 micrograms in one slice of bread. Boiling pasta with a bit of iodized salt provides another 36 micrograms in 1 cup of pasta. Many non-fat yogurts contain up to 116 micrograms of iodine in 8 ounces. 1 cup of non-fat milk contains 85 micrograms. Some seaweeds contain micrograms up to 230, whereas other ones have very little. So you can't just rely on seaweed as your source of iodine, because from one product to the next, you don't know how much iodine is in there. Most fruits and vegetables have very little, as does soy milk. Fruits and vegetables and legumes, including soy products, are healthy choices, but they don't give you the iodine that you need. Some fish, like cod, have a lot of iodine. Other fish, like shrimp, have very little. Tuna has 17 micrograms of iodine at 3 ounces, not very much. So, you can't just say, I eat fish, I'm going to be fine. That's not exactly the case. In our society, most susceptible individuals for pronounced iodine insufficiency include people who avoid iodized salt, pregnant and breastfeeding women because they have an increased need, and vegans and people who eat few or no dairy products, seafood, or eggs. Highest risk. In addition to increasing the risk for neurological defects in their offspring, mild to moderate iodine deficiency has also been linked to increased risk of thyroid cancer in that person, as well as breast and stomach cancer in a number of studies. It's also linked to fibrocystic breast disease, where it can be reversed with iodine supplementation. So here's all the references on iodine that sort of argue the case that I just gave you. So let's sum up what we saw here today. Just a couple of slides. In terms of your involvement, right, sort of as the second eyes in the healthcare system. In patients who show signs of underactive thyroid, like easy weight gain, difficulty losing weight, and other symptoms, especially if they're over the age of 40, find out what their TSH blood level is. And if the doctor's willing to include T3 and T4, that's wonderful. But even if you just know TSH, that's a big start. If the TSH is between 2 and 4, no doctor is going to give them thyroid hormone replacement, but you could start introducing Adëeva Thyro-Support nutrients, and 3 to 6 months later, when they get their TSH blood level test done, if it's working, the TSH level will be going down and their symptoms will be improving. So you can get some objective measurement. Usually the TSH will start to drift down when you give Adëeva Thyro-Support supplements in a case like that. If the TSH is under 1, the person likely already has hyperthyroidism, and they should be arguing that case to their healthcare practitioner. If they have hyperthyroidism, weight gain is not going to be their problem. If the TSH is over 4, most medical doctors are not going to be prescribing thyroid hormone replacement. The person would actually benefit from it if they can argue the case and get it into their body. But even in those cases, giving them also, not instead of, but also Adëeva Thyro-Support formula can help make those medications work better by stimulating more thyroid production and helping the conversion of T4 to T3. If the TSH is normal and they have symptoms of an underactive thyroid, that's present, if you see that the person's under a lot of chronic stress, then adrenal support formula might actually be the best choice to start with. And remember that all people who are overweight and struggling, Adëeva Body Burn is one of those key nutrients, key supplements to be working with, because the green tea catechins turn on thermogenesis, chromium enhances insulin function, and hydroxycitric acid helps to shut off appetite by increasing the synthesis of glycogen, which then through the vagus nerves helps to shut appetite off. So that's Body Burn is sort of that mainstay product. A lot of you are using it, but you may not be clued into the thyroid and adrenal story exactly as they could be incorporated. So in summary, in patients showing signs of slow metabolism, think Thyro-Support, Body Burn, and if stress is a factor, also adrenal support formula. Knowing their TSH blood level is extremely, extremely helpful, because that's something that's done in a routine annual physical examination. If you can also see their cortisol level, believe me, that's also very helpful. But I will tell you right now that many of your patients that you see who are over the age of 35 or 40 have a TSH blood level that's already over 2. Remember, the ideal range for TSH is between 1 and 2. Let's drive that home. As soon as a lot of patients that you see are between 2 and 4, and they're struggling to get back to their ideal percentage body fat and body weight, even though they exercise and their diet's pretty good. Everybody cheats a little. We know that's normal. But as soon as that TSH is drifting higher, Thyro-Support formula can be highly beneficial. So I hope that was helpful.